intrauterine growth restriction, and increased incidence of congenital heart disease like 4 to 6% with more perinatal mortality. So what is the maternal prognosis, which depends on the nature of cardiovascular lesion, functional capacity of the heart, quality of the medical supervision, the presence of associated risk factors, and whether the lesion is surgically corrected or not. So the causes for maternal mortality in cardiovascular disease complicating pregnancy are cardiac causes like cardiac failure, pulmonary edema, pulmonary embolism, active rheumatic carditis, subacute bacterial infective endocarditis, and rupture of coarctation of aorta. And the physiology of pregnancy mimicking the pathology or hyperdynamic circulation, and there will be a systolic ejection murmur at the left sternal border, decreased exercise tolerance, shift of the ventricular apex, continuous murmur at second to fourth intercostal space, that is mammary shuffle, and loud S1 with splitting. These are all the normal physiology of the pregnancy mimicking like cardiovascular disease. So how will you diagnose the cardiovascular disease? If it is needed, then you order for X-ray chest with abdominal shield and then ECG. So in X-ray chest, you may find cardiomegaly, increased pulmonary vascular markings, and enlarged pulmonary veins. And in ECG, there will be a T-wave inversion, maybe biatrial enlargement and other dysarrhythmia. And echocardiography is a must to screen all pregnant women to look for structural abnormalities, valve anatomy, valve area and function, ventricular ejection fraction, and pulmonary artery systolic velocity. So what is NIHA classification? The management NIHA classification. You know NIHA classification, it is not coming in the screen, so I think you can study in the book. And the management depends upon the principles, that is early diagnosis and evaluation of anatomical type and functional grade of the disease, to detect high risk factors to prevent cardiac failure, and multidisciplinary team approach at tertiary care. So what are the therapeutic termination? When you need the termination of the pregnancy, that is when the cardiovascular disease in pregnancy is very endangered, that it is going to affect the health of the mother, then you opt for therapeutic termination of the pregnancy. So the absolute indications are primary pulmonary hypertension, Eisenmenger syndrome, pulmonary veno-occlusive disease, severe systemic ventricular dysfunction, that is when ejection fraction is less than 30%. The relative indications are Paris women with grade 3 and 4 lesions, grade 1 and 2 lesion with previous history of cardiac failure. So what is the antenatal management? It should be in tertiary care hospital. The initial assessment should be with a cardiologist for cardiovascular disease. The special care should be taken to detect and treat the risk factors which precipitate failure like urinary tract infection, respiratory tract infection, dental infection, anemia, obesity, hypertension, hyperthyroid, hypertension associated with the preeclampsia and eclampsia. These are all the special indications where more care should be given. So what is the role of anticoagulant? It is indicated in congenital heart disease, pulmonary hypertension, mechanical heart valve, and atrial fibrillation. These are all the cardiac conditions where anticoagulants are needed. The common anticoagulant used in cardiovascular disease complicating pregnancy is usually in the initial period it is heparin, and then it is switched over to warfarin, and again the warfarin is switched over to heparin after 36 weeks of pregnancy till 7 days of the puerperium. So once the pregnancy is confirmed, you have to start heparin, and then after heparin you should switch over to warfarin, and after warfarin, after 36 weeks till 7 days puerperium, again it is switched over to heparin. So what is the timing of admission? So elective admission for patients when there is grade 1 to 2 cardiovascular disease, and so you admit 2 weeks prior to expected date of delivery. When there is a grade 2 cardiac disease, admit at 28 weeks if unfavorable social surroundings. If grade 3 and 4, as soon as pregnancy is confirmed. An emergency, you can admit any cardiovascular disease patient when there is deterioration of the functional grading, worsening of the symptoms or new appearance of new symptoms, and when there is a pregnancy complications like anemia, preeclampsia, and eclampsia. So how do you manage the labor management? So the induction of labor should be done for obstetrical indications. So first stage of labor, you should manage, ask the patient to be in left lateral recommended position. Nasal oxygen is needed whenever there is a hypoxia, and adequate analgesia should be used. So always you should ensure that the patients are not suffering from labor pain, so there should be adequate analgesia. So epidural analgesia is started for patients in stage 1 labor, and prophylactic antibiotics should be started as soon as the patient goes for labor pain to prevent the infective endocarditis. And if the intravenous fluid is needed, it should be 75 ml per hour. And otherwise, you can encourage the patients to have more of oral fluids. And important maternal vitals monitoring like SpO2, pulse rate, respiratory rate, and cyanosis, and sudden exacerbation of symptoms and signs in cardiovascular disease. So as I have told you, you have to start infective endocarditis prophylaxis during labor up to 48 hours after delivery, which is usually the combination of parenteral ampicillin along with gentamicin, which should be 1.5 milligram per kilogram body weight. So at the spontaneous onset or induction of labor, the antibiotic should be repeated at 8-hour interval. And when there is more infection like prosthetic valves, prior history of infective endocarditis, cyanotic congenital heart disease, hypertrophic cardiomyopathy, you may increase the dose of the antibiotics, or you can put the broad spectrum antibiotics. So in the second stage of labor, you have to always cut short the second stage with the instruments like ventos and forceps to avoid more stress to the cardiac patients. And methyl ergometrin should be avoided immediately after the delivery of the placenta to avoid the more increase in heart load, because after delivery of the placenta, when you give ergometrin, there will be a sudden overloading of the heart by recirculation to the heart. So it should be avoided. And third stage should be managed by the active management of third stage of labor. So there is no place or no indication for cesarean section because the patient has heart disease. But there are some indications for cesarean section which is preferred than the vaginal delivery for patients with the following heart disease like coarctation of aorta, acute aneurysm of aorta or aortic dissection, aortopathy with aortic root more than 4 centimeter, warfarin treatment within 2 weeks, and when there is a primary pulmonary hypertension and heart failure. So the puerperium should be closely observed for 24 hours for the patients who may prone to develop congestive heart failures. So the patient should be closely monitored for 24 to 48 hours with the nasal oxygen and vitals. What I have already mentioned should be continuously monitored for further 48 hours. The volume overload should be treated with the diuretics, and breastfeeding is not contraindicated. So the choice of contraception is barrier methods is the best method for patients with cardiovascular disease complicating pregnancy, and the progestin only pills. Suppose if the patients don't want the barrier method, they can go for progestin only pills or parenteral progestins like metroxyprogesterone acetate depot, which is available as Andhara, injection Andhara, or metroxyprogesterone acetate, depot metroxyprogesterone acetate, which is safe and effective. And usually intrauterine devices are the risk of infection. So as much as possible, you have to avoid the intrauterine devices. And steroidal contraceptive is better avoided because of the complication of thromboembolic phenomenon. And if the patient has completed the family, you can opt the permanent sterilization like vasectomy for the husband. And if he is not willing, in such cases, you can go for permanent sterilization in the mother. So how will you treat the patients with cardiac failure? Patients should be in propped up position. Oxygen should be administered and monitor the patient with the ECG pulse oximetry. Diuretic should be given and injection morphine is given with 0.5 milligram intramuscular along with the digoxin 0.25 milligram. And if there is a tachyarrhythmias, you have to give adenosine, which has to be 3 to 12 milligram. If there is dysarrhythmia, quinidine or electrical cardioversion, and in some cases mechanical ventilation is needed. So peripartal cardiomyopathy is a diagnosis of exclusion. When there is what is the criteria to say that the patient is going for peripartal cardiomyopathy? That is called PPC, cardiac failure within last month of pregnancy and within 5 months postpartum. Then you should suspect of peripartal cardiomyopathy. When there is absence of previous heart disease, when there is no determinable cause for failure, and when there is left ventricular dysfunction as evidenced on echo when the ejection fraction is less than 30 to 45%, with the left ventricular diastolic dimension more than 2.7 centimeters per meter square. So how will you manage the PPCM? The clinical features are breathlessness and cough. So you have to remember the patients who develop cardiac failure within last month of pregnancy or within up to 6 months postpartum, you have to suspect of peripartal cardiomyopathy. So the clinical features are breathlessness, cough, nocturnal dyspnea, palpitation, tachycardia and tachyarrhythmia, pulmonary edema. So the patient should be treated with bed rest, digoxin, along with the diuretics, beta blockers, and anticoagulant therapy. So I conclude this topic. It should be a multidisciplinary approach for the patients of cardiovascular disease complicating pregnancy. Should be managed by obstetrician, cardiologist, neonatologist, and physiotherapist. So it is a multidisciplinary approach in cardiovascular disease complicating pregnancy. So I think I am audible and my slides were visible. If you have any doubt, I am ready to answer your questions. Can you answer? Am I audible?
Yes, ma'am. Yes, ma'am.
If you have any doubts, I think it is more than enough for you. So you have to know what are the common cardiovascular disease, especially mitral stenosis. I have not discussed the type of the cardiovascular disease. So the commonest cardiovascular disease is the rheumatic heart disease. Among the rheumatic heart disease, mitral stenosis is the commonest cardiovascular disease. So mitral stenosis, mitral regurgitation, aortic stenosis, and tricuspid regurgitation. So the commonest cardiovascular disease complicating pregnancy or mitral stenosis, mitral regurgitation in the order of priority frequency or mitral, tricuspid, aortic, pulmonary. Any doubts you have? And you have to know about the normal dimension of the mitral stenosis. What is the normal dimension of the mitral valve? When will we say it is a critical severe mitral stenosis? When the mitral valve orifice is less than 0.8 centimeters square, then you have to diagnose it as severe mitral stenosis and the patient should be taken care of well, and early referral and institutional antenatal management and intraportal management is mandatory. When the patient has many other, suppose if the patient has severe mitral stenosis, say about in 12 weeks of pregnancy, and if the cardiologist feel the patients may require valve replacement, then valve replacement, you can allow the valve replacement for further progression without any complications in cardiovascular system of the mother. So you can allow the patient at 20 weeks of pregnancy, valve replacement or valvoplasty can be done. So these points also you should know when valve replacement should be done. So the preferable period is 18 to 24 weeks of pregnancy. Anything you want to ask me, I am glad to answer your questions. Who is the class representative is available?
Yes, ma'am.
How many of you have attended? And you keep the attendance and you can bring it when you come for the class to IOG next time.
Okay, ma'am.
Okay, how many of the students have attended?
Ma'am, around 215 students.
Okay. Am I clear to you? Any doubt? Please ask me.
Ma'am, valvuloplasty is performed in pregnant women, ma'am.
Yeah, you can. Suppose if you think that the valvuloplasty or valve replacement will benefit the patient to continue the pregnancy further, you can allow the patient for valvuloplasty or valve replacement in critical mitral stenosis, where the diameter of the mitral valve is less than 0.8 centimeters square. The outcome of the patient is good. You
Ma'am,
can.
but general anesthesia would be difficult
No,
in
that depends upon the anesthesia. Usually it is done under the general anesthesia, isn't it?
yes.
So with adequate tocolytics, if the surgery is, now the procedures are very less invasive. There is so much advancement in the valvuloplasty or valve replacement and they do in less hours with less anesthesia, less anesthetic medications. So by doing that, the patients can continue the pregnancy without further complications, without further deterioration in the maternal condition. So it can be allowed.
Okay, ma'am. Thank you, ma'am.
Thank you. Can I close the slideshow? Can I leave?
Yes, ma'am.
Okay. Thank you.
Thank,
Thank you.
thank you, ma'am.
Thank you. Thank you. சரி எடுத்துக்கோ. இன்னும் கொஞ்சம் கூட நல்லா ப்ரிப்பேர் பண்ணிக்கலாம், டைம் இல்லை இவ்வளோதான்.
நான் பண்ணிடுறேன் மேடம். அப்படிதான் நான் பண்ணிடுறேன் மேடம். அவங்க யாரும் பண்றது இல்லை மேடம், நானே பண்றேன் மேடம். அவங்க யாரும் ஆமா மேடம், கண்டிப்பா அது வந்து கண்டிப்பா மேடம் நான் பண்றேன் மேடம்.
எல்லாமே நான் நிறைய சர்ஜரி பண்றது என்னுடைய ஓன் இன்ட்ரெஸ்ட்.
கண்டிப்பா
போன்ல யாருக்கு
இது சோலை மேடம், நான் ஃபோன் பண்ணி சொல்லியிருக்கேன், நான் பண்ணிடுறேன்.
நான் நாளைக்கு படிக்கிறேன்.
சரி
வந்து கிளாஸ் இருக்கு.
சரிங்க மேம், தேங்க்யூ மேம்.